think we also dealt with quality management systems, quality management systems as well, network optimization. Sorry, I was supposed to go back. All right. All right, so demand creation, result utilization. I think we also, in the era of HIV, TB, and the COVID-19 pandemic at the same time, we just need to make sure we maintain essential testing. We also dealt with monitoring and evaluation, as well as waste management. And in all this, for this to work, in addition to the action plans, we need to find where we can find the money to do this. Otherwise, this will all be in vain. So basically, it's a summary. Even if I were to stop here, that would maybe suffice. So I'll just quickly go through here without talking that much to try and save time. So in terms of increasing access, I think you remember these are just some of the highlights that you saw as we went down the year. We talked about the TB lateral flow assay, where we are saying probably it could be the only true POC test that currently available for TB diagnosis, and it's trying to reach that last mile. We also went to talk about screening of latent TB and talking about the IGRA and its ability to reach that community level. I think those are some of the highlights that we have. So I'm just picking a few sort of flagship slides that came through in these. And also talking about really increasing that access where we cannot be able to collect things like plasma. We also talked about how effective the plasma separation card as an alternative to TBS could also be working out. And in terms of laboratory quality management systems, I think you remember how the TB scorecard by FIND, GLI, CDC, PEPFAR was also developed, and how this could actually be working through our systems. And I think this is another important best practices that we learned in terms of assay verification, which is a bottleneck currently in most of our settings where we can't do issues like probit analysis, things like that. So I think this is a tool that will be very handy to be able to automate that process and bridge that skills gap. I think we also saw how performance of the TB has been very useful from South Africa. In terms of network optimization, I think this needs no introduction. The main issues we discussed are around how we do our network planning, the optimization itself, and how to transform it. And I remember in one session, I think Dr. Pascal really nailed it when she said unlocking the power of that tiered network using laboratory mapping. And we learned that this is happening actually in a number of African countries, as you can see here. And in addition, diagnostic integration coming through. I think this was a slide from George in one of the sessions. And remember our Tanzania colleagues talked about the power of integration, and this is quite useful, especially in this era where we have so much investment in diagnostics, and what are we going to do even beyond the pandemic. Still, this is quite useful in terms of really improving that access and moving to areas where you actually need the test to be. And all this cannot work without really creating that sufficient demand. And ITPC colleagues came through, and one of the best practices is really to do those targeted campaigns where you are doing awareness and creating demand for routine testing. And these are some of the countries that this was done in. And these are some of the methods that they used in terms of Twitter and social campaign, and we had effective results coming through. Also ensuring that test results are actually delivered and actually utilized. We actually also had quite a lot of best practices coming through there. I think of note is the electronic delivery of results that's coming through, and then a component of actually getting the result to the patient itself and empowering them. I think that's another one that came through. And the element of dashboards in the M&E practice, community of practice, I think we touched on dashboards. That also is an effective way of monitoring a bird's eye view of our systems. The South African Results for Action dashboard is also one potential best practice that we also learned that is crucial. I think this captures the importance of data quality assurance, I think, for us to be able to also make better decisions. And this was given from the WHO perspectives. It will not be, I will not have done justice if I don't mention our work throughout the pandemic, where we talked about testing strategies around COVID, and for examples, things like pooled testing, they keep on coming through. In the era of COVID-19, I think importance should be put on maintaining testing, and these are some of the strategies that were actually shared that could actually be used to maintain such. I don't want to forget that waste management puzzle. I think this has also been a topical issue. I don't have time to go through this, but these are some of the treatment technologies that are there and where they are actually applicable. And WN colleagues have actually tried to make sort of a flow chart in how you can actually select the most affordable and safest methods that are there. As I conclude, I think we will not always forget where we could actually be getting the potential funding to be doing this. So we also had our colleagues from the Global Fund and PEPFAR also sharing how we can actually fund these best practices. Some reflections as we go into these sessions. Our contexts vary, and should we be sharing best practices or failures? These are all best practices we are sharing, but how can we learn from these and actually take them to scale? So I went very fast. Hopefully it was not too fast for the translators, just trying to catch up on time. Over.
Thanks, Anafi, for that great presentation. I appreciate trying to keep time, and yeah, we are seriously behind time, so any savings will be greatly appreciated. Our next speaker, again, is my colleague and friend, Dr. Karidia Diallo, our CDC lab branch chief in South Africa. Karidia, it's my distinct pleasure to welcome you to share highlights on the success on country intervention, return of results, of test results. So Karidia, please take it and run with it.
Where is it? My connection is stable. So good afternoon, good morning, colleagues. I would like to thank the organizers of the 2021 LabCoP meeting for the opportunity to share our experience on result return to healthcare facilities. Thank you, Dr. Z, for the introduction. My presentation will cover the why of our approach, an overview of the system we are using to send results to healthcare facilities, and I will also talk about the project milestone followed by challenges and lessons learned. I will end by presenting the benefit and new developments. Access to laboratory results and appropriate action by healthcare workers on the abnormal result is critical for patient clinical care. The picture on this slide depicts some of the result delivery system in South Africa. We have eLab, SMS printers, and LabTrack. Other result delivery mechanisms include hard copies and the telephone result delivery. In South Africa, a civil society monitoring project highlighted that patients and healthcare workers both have a poor understanding of the viral load monitoring a cascade. Only 68% of clients indicated that they understood viral load and HIV transmission, while over 17% of clients indicated that the healthcare worker did not explain to them the viral load results. Therefore, it is critical to improve patient literacy and strengthen provider knowledge for HIV viral load and to ensure that both provider and patient have access to and understand viral load results. PEPFAR South Africa is striving for universal lab test uptake, result to return, and understanding. Therefore, CDC intends to lead PEPFAR and the South Africa HIV response in committing to achieve a universal lab test uptake and aims to achieve the goals of 95% of viral load result to return to providers and patients, and 95% of understanding by provider and patient of what viral load means. eLab is one of the tools we are using to achieve these goals. The rest of my talk will focus on eLab. So what is eLab? It is an app on a mobile device which tracks and traces specimens from when they are taken from the patient to when the courier collects the specimen from the facility to when he delivers them to the lab for testing. As soon as the results are authorized by the lab, they are electronically sent back to eLab device at the facility for the healthcare worker to receive. eLab allows for results to be received quicker than standard method and has the added benefit of alert for abnormal results that require action, for example, unsuppressed viral load or rejected specimen. The primary indicators we are measuring through eLab are turnaround time, specimen rejection, and result rate. The initial project started in 24 facilities in Gauteng province in 2018. An evaluation was then performed to assess the feasibility and usability of the app, and several enhancements were made to the minimum viable product. And in 2019, eLab was scaled up to more than 500 facilities and in 4 provinces. And at that time, by December 2019, we were seeing some reduction in turnaround time from 108 hours to 70 hours. And the number of facility increased, of specimen went from 1,500 on eLab to 314,000. So as we speak, eLab has been implemented in more than 2,000 facilities in 24 districts for HIV viral load and COVID-19 PCR and antigen tests. New features include the addition of further tests, the feature of electronic order entries, viral load monitoring dashboard for clients with abnormal results, and piloting a patient support system, which involves sending result outcome directly to patient, as well as lab test appointment reminder and educational messages. So these are the list of some challenges and lessons learned. Because of for the sake of time, I will not go through all of them, and I know you will receive the presentation. So one thing I want to highlight is that engagement with stakeholders across all levels of the Department of Health, NHLS, and support partner hierarchy was needed for sustainability beyond implementation. With rolling out a tool such as eLab, monitoring of the devices is critical to ensure success of the program. In fiscal year 2022, which is the fiscal year we are in right now, a new strategy for monitoring eLab will be launched called ECQI, which stands for eLab Continuous Quality Improvement. This is a strategy based on the rapid test continuous quality improvement strategies. It will involve measurable indicators and will use a scoring system to rate facilities from poor performing to good performing facilities. Continuous engagement with the National Department of Health and the Provincial Department of Health and stakeholders, as well as dedicated technical team to support eLab are needed. So what are the benefits of eLab? Well, the device is placed at facility level, so results are accessible every day by facility staff. They do not need to wait for hard copy results. There is no need for internet connectivity. eLab can work where there is limited connectivity. There is no need to search for a specific patient result, although the feature is available on the device, but rather notifications are sent for any abnormal result and can be viewed daily. These appear as notification and so are easy to view. eLab also allows for visibility as to how many results have been read by healthcare worker at facility level. ELAB is not thought to be a replacement for other NHLS result delivery mechanism, but rather complementary, because we believe that the more tool we have to send result to provider, the better it is for our program. What are some new developments that we have added to the device? They include the development of the viral load monitoring strategy using ELAB as a tool. So ELAB user collect number of invalid, rejected, or unsuppressed viral load results in ELAB. Secondly, they also collect number of clients with invalid, rejected, unsuppressed viral load result contacted by healthcare worker within 2 to 4 weeks of result reception at facility level. And the third indicator is the number of clients with a final outcome. And the final outcome is about the number of patients returned to the clinic, either for a repeat viral load test, or if they receive enhanced adherent counseling or ARB regimen switch within 2 to 4 weeks of the result reaching the facility. We have also developed job aid and a data collection template to assist the facilities with monitoring of patient and collection of this data. So what we have noticed is that to be able to use this dashboard efficiently, training was needed. And more concretely, virtual training we have shown has been shown to be an effective and efficient method for improving health facilities performance on HIV viral load result management. This is a poster that was presented from my team at ASLM 2021. As you can see, there were 19 training sessions and more than 1,000 healthcare workers were trained. So talking about new development, what we have done is also adding a module to the device, which is the patient support system. It forms part of an integrated approach to improve HIV viral load coverage. And what it does that viral load result outcome are sent directly to patient via their mobile phone. We also send them their appointment reminders as well as educational messages. This is a pilot being piloted right now in country on 2 sites, one rural and one urban. So far, more than 300 patients have been enrolled in the study. And the analysis of the data provided by the study will inform the scale up of this patient support system countrywide. So this is the workflow. I will not go through it. It's a slide that is pretty loaded. It's just how the patient and the provider are working inside the facility when it comes to the implementation of the pilot study. So these are a list of challenges we have been facing as well as lessons learned. And as we go along with the study, we are enrolling patients where there are system iteration taking place to make sure that we are making the system very user-friendly for the patients who are enrolled in the study. So the challenges that are listed, I will not go through the list for the sake of time. And yeah, addressing these challenges are very important for the implementation of the study. In conclusion, ELAB forms part of an integrated approach for result return, understanding. It's not a device sitting by itself at facility level, but it has to be integrated in the system that is in place. I would like to acknowledge my colleague and institution participated in this study. First, my colleague, Dr. Lee Berry and Paula Wheeler, who is a fellow in my branch, the National and Provincial Department of Health, the district and healthcare facilities, the National Health Laboratory Services, and the National Priority Programs, specifically Professor Wendy Stephen and her team, Beach Health Consortium, who is managing the COAC for us, Mezzanine developing the app, and PERFA district support partner who are heavily involved in the implementation of the program at facility level. Over to you, Clement. Thank you.
Thank you so much, Dr. Karidia, for that excellent presentation, returning results back to the facility. That's wonderful. In the interest of time, we'll just move to the next speaker. Our next speaker is going to be presenting waste management solution. Again, this is another best practice that we talked about. It's really important for us to have clear solution, especially with waste management, with all the challenges we're having. So it's my colleague, Monte Martin and David Bressler from the CDC Atlanta team that will be presenting some solutions to waste management. Monte, please take it on, and David, take it around with it.
Thanks, Clement. Dave is going to present on the slides. Thank you. Over to you, Dave.
Thanks, Monte.
Okay.
David, go ahead.
Let me go ahead and share my screen. And let's see. Can everyone see that?
Yes, we can. Go ahead, David.
Okay, great. This is gonna, I'm hoping that I can make the 10 minutes. I don't know, we have a lot of slides, but I will try to reduce everything if I can. I'm going to turn off my screen as well, just so everything works, and we're gonna get started here.
Thanks,
Okay.
David.
Good afternoon, everyone. I'm David Bressler from the CDC International Lab Branch in Atlanta, and I want to thank you all very much for this opportunity. In the next few minutes, I hope to give everyone a very brief summary of our activities regarding the management of laboratory waste containing guanidinium thiocyanate from molecular laboratories. And when we are talking about molecular laboratories, we're speaking in the context of viral load and early infant diagnosis, VLEID labs in PEPFAR supported countries. I am the part of the laboratory system strengthening team here in ILB. Now, I think this first slide is pretty obvious in its message. Hazardous waste is truly a global problem, and the more healthcare and laboratory sites that there are, the more waste that is produced that must be managed and disposed of. If not managed properly, it poses an increasing and very significant public health threat. Over the past 2 years, the COVID-19 pandemic has significantly increased the amount of healthcare and laboratory waste needing to be disposed of. And as we're all well aware, much of this COVID-related waste, like used masks, is currently not being disposed of properly. And unfortunately, that's a topic for another discussion. So just to kind of set the stage, this is how things really began, and this is how ILB got involved with this issue of GTC waste. This is just an example of how much liquid waste can be produced from these high throughput platforms. And what we're looking at are basically, I think, basically 4 or 5 liter containers, and this one actually has charcoal in it as well. So this is the type of and amounts of waste that are coming off of individual platforms, and you can imagine what happens on a daily basis. So in this slide, we have just a little bit of background on what we're getting into. Really, what we're talking about is that it was estimated that by this year, 2021, that more than 30 million viral load tests would be performed. And this, you can read there basically what we were talking about. That was not really including COVID issues, which basically brought these platforms online to do COVID diagnostics as well. And so added immensely to the amount of liquid and solid waste that was being produced. So the real important bullets are what comes next. And what we found was that almost all current testing platforms contain guanidinium thiocyanate. Basically, in order to, the GTC is included in order to break down viral membranes and stabilize viral nucleic acids for PCR. In our research, we found that one of the main issues with GTC was that you could mix it, and if it did get mixed with common disinfectants, it produced a hydrogen cyanide gas, and that's a very bad thing. The other things that we found were that mainly the facilities that we're dealing with usually didn't have the infrastructure to deal with it. And in addition to that, manufacturers were kind of protective of their proprietary information and did not give much information about how much GTC was contained in their platform components. And so we had to do a lot of investigation about that. And they did not include manufacturers' recommendations for disposal either. We did understand that if this material was poured down the drain or put into a burn pit, it would most likely end up in the regional drinking water aquifer, and that would have significant public health implications for future generations. So with that background, we had to figure out what the real situation was. So beginning in late 2018, we began to formulate these questions, and I'm not going to spend a whole lot of time on this. You can basically read what we were dealing with. What we found out was we needed help in getting those answers. And in November of 2018, we began active collaborations with ASLM to bring awareness to the subject through ASLM's LabCoP Echo Distance Learning platform. By doing this, we were able to reach the desired audience and garner country leadership engagement, as well as manufacturer and NGO support regarding viral load waste management problem. So as part of that initial LabCoP familiarization session, an informal poll consisting of 6 questions was provided by ASLM in the chat box to the participants. One answer to a posed question of how liquid waste was handled and disposed of was pretty consistent for the 6 countries that responded. That, you know, what we already knew, that material was often just simply poured down the sink. At that point in time, CDC, in collaboration with ASLM and a few platform manufacturers and NGOs, distributed a preliminary tool to help facilities do a gap analysis on their waste management processes and procedures. And you can find this document on aslm.org. We also had some background information on basically the fact that there was a lack of knowledge about available waste management strategies and options, and only due to the initiative of some individuals where they were able to kind of think through the situation and do some rather interesting experiments. In Mozambique's case, they were able to absorb their liquid waste because they were running out of storage space for all the liquid waste that they were accumulating. They decided to try to absorb the waste into charcoal. And it was only because Mozambique had access to a cement facility where they made cement, and that cement is typically made using a cement kiln. And cement kilns produce the cement, and some producers are amenable to incorporating waste as part of the calcination process. The cement kilns will handle large quantities and is generally a cheap and effective disposal option. However, the waste must have caloric value and add to the temperature of the kiln. Otherwise, it's just like dumping water on a fire. It brings down the temperature of the kiln too much. The solution that Mozambique arrived at was to absorb the liquid waste into this charcoal, and as the charcoal now would add caloric value to the kiln temperature and turns the liquid into a much easier dispose of solid waste. Unfortunately, this option does have limitations. It is very labor intensive and it's very dusty work. Let's see. So what we found out in 2019, after we began collaboration with well-known waste management organization Waste Not Want Not, who was very experienced in international waste issues, that it wasn't just the GTC waste that we were going to have to figure out. Here you can kind of see that the GTC waste is way down here at the bottom, but there's a lot of tangential waste issues that we were going to have to consider as well. So at this point in time, we were able to identify solid goals and activities that could help. I'm not going to spend a whole lot of time in this, but you can see some of the harmonized goals and activities that we came up with. Much of these activities were accomplished because Waste Not Want Not has a chemist as part of their team. And their chemist was able to develop a simple analysis for determining the amounts of GTC in the proprietary ingredients as well as in the effluent waste by platform as well. And that assisted us with determining sustainable and safe disposal options based on in-country resources. You can see in this slide that one task was to develop a waste management decision matrix. And we can talk a little bit about that a little bit later, but for now, I'm going to kind of try to move through my slides a little quicker. In addition, our collaborations have not only included waste management companies and country offices and MOHs, but we've also partnered with manufacturers. One of those companies is Roche Biomedical. This collaboration is a result of a public-private partnership that CDC has with Roche, among others. In this PPP, Roche and CDC worked over the past 2 years to develop a quantification and waste cost calculation tool. Right now, we're calling it a waste cost assessment framework, for lack of a better name. Excuse me. Currently, this protocol is in clearance, and so I can't speak a whole lot about it, but you can see some of the ideas that we have going into it. We feel that it is innovative and pioneering solution. It's really the first example of a comprehensive approach to overall healthcare waste management cost estimation. What we have, and this sort of gives a little bit of the key attributes to this tool, and I will let this to you whenever ASLM distributes the slides that you can read through this. I think that it gives a pretty good background as far as what we consider to be key points. We've also teamed up. Let's see, okay, so back for 1 second. We foresee that the tool as being a very useful way for programs and countries to generate an aggregated dollar figure for input into the COP planning process. The tool is agnostic, meaning that it is not dependent on the manufacturer of the platform that you're using. But because it's also in clearance, I can't say very much more about this. That sort of thing brings me back to our collaboration with Waste Not Want Not. Here you can see that we've come a very long way from that first innovative and resourceful strategy for absorbing liquid waste into charcoal for feeding into a cement kiln. That's just one strategy that we have evaluated with Waste Not Want Not. You can see some of the other disposal methods that we have looked at as well. One of the most promising is a novel method of chemically binding the GTC and removing it as an insoluble and non-toxic precipitate. In keeping with our mantra of safe and effective, but also sustainable, this precipitate can be reutilized as a non-toxic paint additive to enhance spreadability and coverage of paint. The precipitate can also be sent to metal processing plants to recover economically valuable amounts of copper metal from that precipitate. We've been evaluating numerous other strategies, and these will be published shortly for country and laboratory review. Anafi has already discussed this slide, but what it really gets to is that obviously just because you have options does not mean that they are the right disposal options for your laboratory or country circumstance. CDC and Waste Not Want Not are working to develop a multi-criteria treatment option analysis tool to help countries and laboratory facilities decide between the available methods. The diagram that you see in this slide only gives a few of the considerations for determining the most appropriate, safe, and effective disposal method. We foresee that this protocol, excuse me, should also be cleared in the next few weeks, allowing us to start coordinating with country offices for the necessary education and training that will help move this project forward. So in conclusion, what are our next steps? Well, obviously, getting these things through clearance is one of the big things, and we will spend our priority. This is a major priority for us right now. So additionally, we want to continue working with all of our partners in our national policy frameworks, making them more easily understood and easier to adopt and enforce. We foresee that once that last protocol is approved, being able to start the process of education and training on these waste management strategies in PEPFAR supported countries. And during that time, we would be assisting countries with selection, implementation, and scale up the waste management strategies that we've evaluated, and also include metrics and evaluation aspects as well. As we move forward, we will be improving country capacity for waste management by training personnel on appropriate, safe, and effective process instructions. Ultimately, we want to bring together all levels of waste management, stakeholders, partners, and collaborators to really make a difference for dealing with GTC-containing laboratory waste. And I really want to thank, for our laboratory branch, Heather and Clement and all of the others here that you see who have really made so much happen with this multi-pronged project over the past few years. Thank you for your attention. And I will stop sharing now.
Thanks, Dave, for that wonderful. Thank you so much for that excellent presentation. Again, I just want to remind people that there are questions in the chat. The chat is very active, and I'm very happy to see that the questions are being asked. People are responding to it live, so I think this is quite amazing. So please keep raising your questions, your comments on the chat so that we can get live discussion at the end. So, and for those that can respond to those questions, please keep responding to those questions that are coming up on the chat. Now, our last speaker in this session is our own Solange Baptiste from ITBC, and she will be giving the last presentation. I think it's an exciting presentation. Again, we all know how great work that she has been doing. So it's an opportunity for us to hear from the community initiative in addressing gaps in assessing access to diagnostic tests. So Solange, welcome. It's my distinct pleasure to welcome you to go ahead and share your experience, the best practice that you have been working on. Thank you, and take it over.
Thanks, Clement. 1 second, let me see if I can share my screen. There we go. I think we should be in order now. Are you guys seeing that? Just making sure.
Yes, we are seeing a screen. Please go ahead.
Thanks. All right, so good day, everyone. Thanks again for inviting ITBC to share our perspectives from around the partners that we've been working with to talk about the ways that communities can help to address the gaps in access to diagnostics. I'm Solange Baptiste. I sit in Johannesburg in South Africa, and I'm the executive director at ITBC. So at the risk of kind of stating the obvious, I just wanted to zoom out and just say, you know, diseases or conditions must be identified before they can be treated. And obviously this is where we all sit. And this is important to bear in mind as we zoom out and we take a look at our context. And the context there being our larger goals of universal health coverage and our sustainable development goals of ensuring healthy lives and promoting well-being for all at all ages, where HIV is now in the laundry list. And if we look at even our UNAIDS HIV targets, they are dependent upon making evidence-informed decisions, resources and people, political will, and in particular, trying to get to this 95, 95, 95 as our 2030 target, we need reliable and whole data. We need to see what is really happening all the way through the cascade. And this requires us to be able to see what's happening with key and subpopulations, but also we know that diagnosis is the weakest link in the care cascade, and detection of HIV in large numbers of people is critical to be able to get to any of these targets. If we look deeper into the context, we know the persistently high levels of death due to HIV. I think in 2020 alone, in the red box, you'll see we were close to almost 700,000. And our 2030 target of having that be less than 400,000, you see here in the orange box, is met with the stark reality that in many countries, 30% or more of new patients still present with a advanced HIV disease or AIDS. So we are really having to look closely at our context in order to determine what kinds of interventions and where can communities really step up. In addition, we have the more updated HIV cascade that looks more like the reality on the ground, right? We used to have this linear view. Now we looking here, in addition to late clinical presentation, we have the frequent periods of engagement and re-engagement into care. So re-diagnosis, relinking, re-initiation, and re-engagement. So making this 2030 target name possible without better access to these key diagnostics to ensure good health and save lives. All of this is in the context of broader challenging trends that I thought I should raise, in particular looking at primary health care from the provider side and how communities and recipients of care and patients view what's happening around. And I'm pausing here because we often overlook primary health care as a critical pathway to universal health coverage and to saving lives, right? The WHO estimates that about 80 to 90% of a person's healthcare needs can actually be addressed at the primary care level. And the most common entry point into care here would be strong diagnostic capacity to keeping communities healthy and identifying and preventing the spread of disease outbreaks and disease itself. So in terms of the trends that I wanted to highlight, you think about standardized mystery patient studies and show that they show that primary healthcare providers underdiagnose and overtreat. When they're faced with sick patients, they tend to use non-specific empirical therapies. Something will work, let's try. They also have now looked at the out-of-pocket costs and the prohibitive financial burden on recipients of care. I think someone is not on mute, so if the organizers can help with that, that would be great. And then the WHO also estimates that only 1% of primary healthcare clinics have the basic diagnostic capacity that is necessary, especially in low and middle income countries, and that was an estimate in 2020. So what is the community perspective on diagnostics? I think we need to interrogate a little further. Who are these people and what are their attitudes towards seeking health? If we want to look at that first part of the cascade, there's a pervasive notion that unless you're feeling ill, you don't need to see a doctor. There's no real need to go. But we're talking about people who are sometimes unwell and in hospital and then discharged with maybe more complicated and sometimes confusing outpatient linkage. Where diagnostics are critical to being able to do routine tests and triage. You can be unwell and in home, non-clinical setting, and this is for various reasons, preference, socioeconomic, environmental factors. And then all those who are well, those who feel okay but have perhaps advanced HIV disease, or by the clinical definition, or what we call the walking well, right? They feel well enough but are at risk of serious health problems. And you can see obviously that it's critical then that we use the correct diagnostics interventions there, and we devise strategies and interventions to meet people in their context. So it's important to kind of just pause and think about that. So we know this, recipients of care want exactly what you want, because you at some point will be a recipient of care, because we all have to manage our health. You want to find quality services close to where you are. You want the option to do the right test at the right time and get your results so you can move on with your life. And we know the discrete choice experiment that was looking in Zambia, saying that people are willing to wait 19 hours and travel 45 kilometers out of their way in order to get to quality. But the challenges that recipients of care face is that they are limited quality services close enough to where they are. They're not always offered the option to do the right test at the right time. And several different tests are required to be done at different places at different times. And then sometimes they're prohibitive out-of-pocket costs. The results, we know all of these things already, but this is also just restating it from the patient or recipient of care perspective. The results take a long time to be returned. The result is then not always used to make timely clinical decisions. for clinical action, you know, and then they would much prefer to obviously have treatment in one place to address their holistic needs, right? So if I'm coming in for a viral load test, can you also do these other diagnostic tests to make sure that I'm healthy generally? So what are these community interventions that are available and have been, we can pull examples of to improve access to diagnostics? So one of them is about increasing demand. And I think about the presentation before with David and how, you know, increasing demand is great, but then we also have to manage the waste. But, you know, we have to do all these different streams at the same time in order to address the problem. So we've had, as others, Collins and Afi and others have talked about, worked within the work here to increase demand for viral load testing. We developed with our partners on the ground and with ASLM community-friendly communication. We did some trainings in 6 countries, and the campaigns ran from October to January. And this is the campaign at a glance, the audience, the platforms that were used, the greatest reach, greatest media that was used, and just looking at who was leading. So this was really being led by the community organizations in country. And routine viral load test communication campaign run by DRC, PLHIV network across multiple platforms. This is an example of what was being said and how it kind of looked. But what I want to really get to is the lessons learned here and how this can be applied, and can I give you a sense of what is still the challenge and where the gaps still exist. Sufficient time is needed to communicate and reinforce messages. So you can't just increase demand with a few months of spraying people with, you know, good tweets. The effective use of digital and non-digital methods is critical. So social media platforms were effective, but they showed limitations in reaching certain subpopulations, especially rural areas where there was probably lower levels of literacy. And it is important to use peer educators and in-person meetings to reinforce the messaging. And the messaging and the message is more important. I think it also came up in the eLab conversation about the, you know, communication of results and what things mean. So it's not just here are your results, but how do you make it into something that is a relatable message that someone understands and can have now self-care going on, going forward. COVID regulations and restrictions hampered the effective implementation of the campaigns. There were lockdowns, and so certain aspects were slowing things down. So we always have to keep the what is the constantly evolving COVID context and how that's changing the work and the interventions. And the issues that were raised are beyond campaign-only interventions, right? So we still landed at these systemic issues that need to be addressed. In DRC, we know that there were issues. Although the campaign generated interest and knowledge, we had reports of people showing up to the healthcare center, because now you've kind of generated the demand, only to be redirected to another center because there were stockouts. So we still have these persistent issues. And in Sierra Leone, for example, we had the central viral load machine, which was not operational. So we have the systemic issues. I will try to go faster because I know you asked for about 10 minutes. So we can do more than engage communities for demand creation. And I think that's something where we need to apply our minds collectively and think of what else can we do. And one obvious one for us is really looking at the demand side and community-led monitoring, the critical part of the whole data story, and making sure that there is a section of input of data that's coming from the community. Community-led monitoring, for those that are unfamiliar, is a process whereby communities themselves engage in routinely monitoring issues that matter to them. So if we think along the care cascade and we think about diagnostics, what do communities want? What are they interested in that either sometimes are triangulating with what's already being collected, or it's absolutely just missing. And here they will come now with this data and co-create solutions that for problems that have been identified. So this is the whole process here in the diagram at the bottom right. You know, they have to understand the standards and what they should be getting as communities and recipients of care. So it starts with education, and then evidence is collected routinely, engagement and advocacy. That's the process. This is the process of community-led monitoring, which you can see from the slides later. This is not something that ITPC came up with. It's actually global rollout of this, and it's hopefully being done at scale soon. PEPFAR, UNAIDS, Global Fund, French 5%, all have engaged in this. In fact, it's part of the COP guidance. And there are different definitions across the different multilateral agencies, but they all emphasize different parts, but it's essentially quite similar. And there are real results that can be generated as a result of community-led monitoring, right? So this one was looking at stockouts. This slide refers to work in a regional community treatment observatory across 11 countries in West Africa. This was funded by the Global Fund. You're looking at stockouts, viral lab supply stockouts, and length of days of ART stockouts, and those should decrease, right? They shouldn't increase. And so these were in monitored sites over time. And the bottom row is things that should increase, did increase in the monitored sites over these 3 periods of time: quality of care, viral load tests performed, and viral load suppression. We also looked at stockouts. We had quantitative data looking at reasons given for the stockouts, etc. This is also an example of emerging themes of data that in our project in South Africa and Malawi. This preliminary data shows improvement in differentiated service delivery, particularly month-to-month dispensing. People still receiving just 1 month because it's a little different from the COVID guidelines. So we're using this data to advocate for faster scale up of DSD. This slide is another example of data, concrete data that can come out of community-led monitoring. This is showing the importance of disaggregated data. You can digest these slides later when I share them. And these are just an example of resources for us. So I'm jumping straight now into the last 3 slides. CLM for viral load testing and beyond. So that's where we are. What we're saying is can be another area that should be addressed. So the rationale here is that routine viral load testing and other essential services and diagnostics are important. We all know that. There are concrete examples of how community-led monitoring allows recipients of care to carry out the process. They can identify the gaps, they can develop relevant and context-specific indicators, and then they can collaborate with labs and other relevant stakeholders for the co-creation of solutions. There's an untapped value of CLM if it's focused on diagnostics. So why CLM? I think I've reiterated this point. The CLM that's currently being rolled out by Global Fund and PEPFAR does not routinely nor comprehensively cover what is really important to diagnostics all the time, because there are some set indicators. And this allows, if we focus it there, to focus on routine access from a recipient of care perspective. So these will be customized, community-defined indicators, which will be of extremely high value to develop and devise interventions to solve some of these problems. And these problems, these could be quality of service, test turnaround time, test result use for clinical action, the out-of-pocket costs, the reagents and consumable stockouts, machine breakdowns, and the availability of COVID-19 and other essential testing. And these are examples of potential indicators. And just to say the last point here, quality of experience is what will build and sustain demand for diagnostic and health services. So it's really important that we get a handle of the demand side and the recipient of care perspective. This is my last slide. How will we know what we need to change or where we need to intervene before 2030 to reach all these targets? It will be really impossible to do that unless we're hearing what's happening from the recipient of care perspective. And I think community-led monitoring is a critical tool in our arsenal that can be applied in the lab context. Thank you.
Great, thanks Solange for that wonderful presentation, and thank to all the speakers, especially for keeping time. I know it wasn't easy. We had so much to present, and really appreciate you managing your time so well. And I just also want to more or less highlight some of the dialogue and questions and comments going on the chat. There have been a lot of questions and response. So I would like to give opportunity to some of the response and our speakers to respond to some of these comments. If we look at some of these comments, a lot have been addressed on the eLab, especially the eLab. There have been a lot of questions that have been raised, some have been addressed. But I would like to give the speakers of eLab, the South African team, to respond to, I think, some of the unanswered questions, some of the questions that have not been answered. I know Dr. Karidia had to step out for another meeting, but her team is here, so I'll give them 1 or 2 minutes to just respond to some of these comments. I'll go through that, and then the next will be David. Dave, there's some comments. I'll read some of those for you so that you can respond to them. I think a lot of the comments are straightforward, especially asking about, can you share SOPs and explain a bit more about how charcoal can be used for liquid waste. So we'll need you to respond to some of those. Then Solange, the additional question at the end, I just want you to look at Pascal's question and then we'll prepare a response. So I'll give the first floor to the Caridia's team to respond to any questions that have not been answered. And there are a lot of questions on the eLab, so please go ahead and provide any additional feedback in 1 or 2 minutes.
Good afternoon, everyone, and thank you, Clement. This is Lindsay Isherwood. Hi, I'm representing the South African team on the eLab's questions. So I've got the rest of the South African team with me. I see there were quite a few questions around, well, is this a free software? Is it an open source platform? And it's not open source. We do believe that open source platforms do come with their own challenges too, but this is a licensed software. And there was also questions around the ease of implementation. So what we do before we implement, we actually work with the in-country partners and we configure the system to the in-country needs. We look at things like legacy systems. Some countries do have legacy laboratory information systems. They have their own courier systems. So we look at the whole pathology value chain and we assess it and we configure according to that country. So we have scaled up in both South Africa and in Zambia at the moment. And we're doing a pilot in Nigeria and Mozambique. So anybody with any other questions are most welcome to reach out to me personally, Lindsay Isherwood, or any other member of the South African team. Thanks, Clement.
Thank you. Thanks again for that, for those responses. Truly appreciate. So Dave, if you can respond to some of the questions. The key one is actually further explanation on the use of charcoal on liquid waste. And then the second one is actually sharing SOPs. I think, so again, through ASLM or ASLM Academy, I believe this conference is to share best practice. So I believe these are things that can be customized and shared with the rest of the group. Over to you, David.
Okay, thanks, Clement. What we're trying to do is get a number of these products through clearance here at CDC, having them reviewed and gotten out to the folks that need this information. So that is a process, and we're trying to get that done as quickly as possible. Obviously, people want to hear about some of these options that could be used in country, and we are trying to get that information out as well. We're working as quickly as we can with Waste Not, Want Not, who have done most of the reviews and assessment and analysis on this, and they've actually been in country to practice some of the options, in particular the charcoal, which it seems that everyone is interested because it, number one, is resourceful. It's in general cost effective, and it can provide somewhat of a solution to get rid of some of the liquid waste that you have. Now, what I will tell you, and I mentioned this in the presentation, is that this is dusty, laborious work to do this unless you have already have a source of pulverized charcoal, powdered charcoal, that sort of thing. Now, what we are trying to do is put together the training and education, because this is dusty work. It requires some safety consideration of safety issues and things like that. And so all that will be included in the protocols that we distribute. And we are hoping that we have this, or that we are able to get travel taken care of, so we can get some of the folks from waste management and maybe some of our own folks out to participate in the training and education, so we can show you exactly how to do these types of options and waste management requirements. So, and I can't, Clement, could you repeat the second question?
The first question you've addressed on the use of charcoal, and then the second part is to second question is to share
the SOPs.
So, yes.
So I mean, the SOPs will be shared as soon as we can get these items through the clearance process. And as I mentioned, we're working on that as quickly as we can. And we feel sure that we'll be able to get these products out probably within the next couple months.
Thank you, David. Solange, there's a lot of questions that have come in for you. Please, if you can just summarize some of the key comments, just respond to some of these comments in general, then we can wrap up this session. I know we are over time, but thank you so much for giving that brilliant presentation. Over to you, Solange.
Thank you, and thanks everyone for the comments. I think the point I would like to reiterate is that I'm responding to Pascal's comment. Agreed. It's all about this One Health approach, and really, I mean, it is right. We are one human being. My hypertension, my diabetes, my HIV status, my asthma, all needs to be addressed because I'm one individual, and so getting offering diagnostics as close as possible to the point of need is as you said, is really critical. And so I think the CLM, the community-led monitoring, can really help to identify, we just say general things like, viral load testing cascade, and we talk about, but from a community perspective, how do we unpack the pain points for them? And so making sure that then we can monitor those things over time and see if there's a solution that we're missing, because we can't just put blanket interventions over very specific issues. And someone raised a question about QI. And yeah, I think QI is very much complementary to the work of CLM. We're actually working with a number of organizations that, QI is a much more scientific, clear, comprehensive sort of discrete experiments to be able to get to the solutions as you iterate. CLM is a little wider and broader in terms of its process. And so I think those things are super complementary, and I would be happy to continue the conversation and see how next we can engage communities beyond demand creation, right? It's not just come and show up, but there's much more value that communities can bring. Thanks.
Thanks a lot, Solange, for those responses. And again, there are a lot of questions on the chat. I'll just bring the session to a close. But the presenters and speakers will definitely be responding to those offline. Please continue with the question. I think this is why this forum was created, and ASLM, for instance, was created to bring best practices together so that we can begin to share standardized best practices. So we are really happy to see that test tool of public health and medicine have now been strengthened by our laboratory results and best practice. So I'd like to thank all the speakers, I think, for the wonderful presentation. Again, apologies for running late, and we're just only 10 minutes or 15 minutes above time, but we started with over 20 minutes. So again, the session was well run. Thank you all for the wonderful presentation and all best practices. ASLM, we give you guys kudos for organizing this session, because this is it for the lab. We have an opportunity where we can standardize best practices across every single lab. Just look at South Africa, talking about over 2,000 health facilities, getting excellent results from the lab. This is the best practice that we can distribute across not only Africa, but other middle and income countries that need to improve lab quality and services. Thank you. I'll hand over to the next session to Anafi.
Thank you, Clement. So we're moving on. I just want to remind colleagues that are yet to rename themselves in the under participants there to do so that we can easily allocate you to the breakout rooms. So thank you. We need to move on to the next stage, and I would like to call upon Nora, who's going to facilitate the next session on behalf of Dr. Raiva Simbi to take us through the next session. Nora, are you there?
Yes, Sanafi, thank you. And good afternoon, good morning to everyone who is on the call, depending on where you are. So we have heard a lot from what is happening on the ground, what is happening in the field, and the other side to those activities is the funding aspect of these activities. So in this session, we are going to be hearing from two of our main funders, PEPFAR and Global Fund, and they are going to be giving us their perspectives in terms of the funding opportunities and priorities from their respective organizations. So we will have Dr. George Alemji from PEPFAR taking us through priorities for lab strengthening in PEPFAR country operational plans. Then after that, we'll hear from Juliet Byron from the Global Fund, and she's going to be talking about priorities for laboratory strengthening from the Global Fund perspective. Dr. Alemji, welcome, and over to you.
Thank you so much, Nora, for that introduction. And Nafi, I hope you're going to share my screen because I'm not able to do that from my end.
Okay. Collins, are you able to share?
No, but George is a co-host, so should be able to share.
Okay, let me see. Are you seeing my screen now?
Yes.
Yes.
Okay, thank you so much. Again, thanks to the ASLM for this wonderful meeting. I'm George Alemji. I currently serve as a senior technical advisor for laboratory services for PEPFAR ESCAC in Washington. And in this capacity, I work very closely with our interagency colleagues in coordinating PEPFAR laboratory activities globally. So for today, I'll be talking more about the PEPFAR laboratory priorities and what we call a country operational plan or the regional operational plan, depending on the regions and countries that we support. Just to remind everyone that yesterday was World AIDS Day, an important day for all of us, where very, very important and milestone results were shared. Lots of excitement going on despite all the challenges that we've seen over the years with COVID and other the diagnostic challenges. So this, my very first slide, is important because over the years we've been saying that PEPFAR has some guiding principles or pillars. We always talk about accountability, transparency, and impact. And I'm sharing this today because there's an additional pillar called equity. It becomes very critical based on what we've seen, but even with COVID and vaccines, on the need for equity to be on the table. So you see a lot of that going forward with the PEPFAR activities in terms of diagnostics, in terms of treatment and prevention activities. So see it more through the lens of accountability, transparency, equity, and the impact. Just sharing some of those very, very exciting results that were released yesterday for PEPFAR, showing that the PEPFAR program has over the years, through all this collaboration, been able to support a treatment for over 18 million people and over 2.8 million babies born free from HIV, and over 27 million, you can imagine, medical male circumcision. And we have the OVC program that does a lot to support the vulnerable children, over 6.7 million. And most importantly, there is a program called the DREAMS, which is a collaboration between PEPFAR and very, very important stakeholders, and really focusing on that sort of, I would say, a priority population, which is the adolescent girls, the young women. PEPFAR has done so much working with all the stakeholders, a lot of improvement in terms of reaching out to this population, diagnosis, prevention, and so forth. As COVID-19 hit, PEPFAR did a lot in terms of ensuring that all its investments over the years were leveraged to support COVID-19. And of course, there are two words that we also want to use here. We want to protect the gains of HIV and respond to COVID-19. I think this is very important for all of us, that if we don't do that, and we saw that in the past, that, you know, if you don't protect HIV gains and you support COVID-19, or if you support COVID-19 and you don't protect HIV gains, there's going to be, hello?
Internal control, now internal control.
Hello?
Control, now internal control.
Can I go ahead?
Yes, please. I will try to mute the person.
Okay, so I was saying that in terms of really addressing the COVID-19, PEPFAR did a lot in ensuring that its platforms were actually leveraged at all levels. Just looking at what happened, you have ensuring that there was continuity of care of people living with HIV, and also leveraging those platforms we talk about in terms of lab infrastructure, the personnel, the facilities, and also reducing exposure to staff and also patients and everyone involved in terms of infection prevention control and PPE. And of course, being very, very flexible with the PEPFAR plan. And that is the intent, that even though you were using HIV funding to support program, but all that is always leveraged. And we saw it very well during COVID-19, where PEPFAR did a great job in actually really addressing all these gaps in the context of COVID. We have what we call the American Rescue Plan, which are really an additional funding that came in to support the PEPFAR program in ensuring that we address or we mitigate the impact of COVID-19. So just apart from our existing funding that we know, there was over $250 million that came in. And for each of our PEPFAR countries, there was almost like 5% increase in what they could request through the APA funds in addition to what they have. And of course, we have done this very closely with Global Fund to also make sure that there's no overlap between additional funding that went to Global Fund for what we call the C19. So all that has actually strengthened PEPFAR, working with other countries and supporting both HIV and COVID. That is actually being implemented in the current COP21. Very good news, as you can see, despite all the challenges, I think PEPFAR is sharing this exciting news that we saw tremendous improvement in terms of people enrolled into AROT in the midst of COVID. So this is great, and we really want to use this opportunity to thank all the stakeholders, our collaborators, Global Fund, WHO, LSLM, African CDC, and everyone that has really been involved in this process. So good news for all of us. Now, let me just talk a little bit about the PEPFAR, the COP or the ROP that I mentioned. Just to be very, very clear that this process is always very, very inclusive, as we said all the time. Can someone help me unmute this individual again? Okay, so it involves participation of everyone at all levels with all stakeholders involved. I'm sure most of you on this call this morning just recently reviewed our PEPFAR COP 2022 draft guideline. It's just back to us. Thank you so much. Seen a lot of input on the lab aspect, which I'm reviewing this week and next week, and you're going to see all your input reflected in the final document. So that is how PEPFAR functions with the COP guideline. It is all inclusive, it is our document, and all of us are involved in the entire process. So thank you so much. Now, let me just go back to really show some of the important data that we've seen more recently, particularly what COVID-19 did to some of our systems and how we are working to address them, and show that all that are reflected in the current and the upcoming COP guidelines. Just to remind that when we talk about laboratory priorities, the key areas that we always want to focus, looking at the first 95, second and the third 95, the HIV rapid testing is really something that I don't want to belabor the point. And also the need for us to have quality embedded in this testing, the HIV rapid testing, continuous quality improvement is all there. And we all know that quality testing is key to all our programs. Then, of course, the self-testing is what we've seen in so many countries that it really helped to address issues around COVID, because people were able to, first of all, get an indication that something is not right. Then, of course, it can follow through. So there's a lot of involvement and a lot of support for HIV self-testing. And the recency testing that has been rolled out of PEPFAR in the past 3 to 4 years, really showing the impact of using this tool. Is not a diagnostic tool. I really want to say this very clear. It's not meant to replace our national algorithms, but just to determine what we call the HIV hotspot. Is more of a surveillance tool to show where we can pay more HIV prevention interventions. And we've seen that in many of our supported countries. And what's called PrEP, again, is something that is critical being supported at PEPFAR at all levels with all other stakeholders. So that is it for just part of the first 90, but let's just look at viral load. I just want to use this slide to tell the story that PEPFAR program over the years, you can see from the FY19 Q1, right on my left, that the program has done so well in terms of improvement in viral load testing coverage, where we can see from FY20 Q3 right up to FY21 Q2. That means just coming up almost towards July of this year, that there was a flat curve, and this is the impact of COVID. We saw it all over the place. So there's a need for us to think about what do we do, and that is why you see all this additional funding in terms of the APA funds, in terms of really thinking about the new strategies and being focused. And I think I've heard a lot from this meeting that that is the way to go. So we have a lot to do to continue to jump back and be where we were in the past couple of years in terms of really showing that tremendous improvement. Despite that, you can see that there is also continuous improvement in viral suppression, which is the good news. This is another slide really telling the story that, you know, we see improvement in viral suppression, the round, the red circles, despite COVID, which means that for those who are on treatment, they were actually adhering to their medication. But again, a lot has to be done to improve testing coverage. We've seen this all the time also with pregnant and breastfeeding women. The thing is not looking better. We saw this last year, that there's still a huge gap for the pregnant women. Many reasons are advanced for this. Part of this could be the demand creation that we've been talking about. But most importantly, we've come to realize that the data system or the denominator for the indicator is not well utilized. But like the fact that some of these women may be pregnant and the middle of pregnancy, they may not have viral load results, or they may have these results and classified under the general population. So improvement in the data system here is very critical for us to have a good picture of what is happening with viral load testing coverage among pregnant and breastfeeding women. We've seen this all the time again with the population, a huge difference, particularly in terms of the younger population for both viral load testing coverage and viral suppression. I'm going to give a couple of strategies how we can address some of this moving forward. This is something that was shared yesterday, very, very important for all of us to really begin to look at. What are we seeing in terms of the UNA's definition of the 90-90-90, or now the 95-95-95. Yesterday, this is data from the PEPFAR, what we call the FIA, the Community Engagement Surveillance Program, which is really looking at population level viral suppression. So you can see maybe the orange rectangles telling us truly where we are in terms of the population viral suppression, which is different from what we see in terms of operational viral load suppression that we talk about. So a lot of countries are doing so well, and a lot of our PEPFAR supported countries have reached what we call the epidemic control. But despite that, gaps remain in other countries, and there's a need for us to begin to catch up in those areas. In terms of the EID, which we've seen, and I think we saw this right even from the child data and WHO, that the impact of COVID on the EID wasn't that so much. So you can see the PEPFAR data mirroring what you see or what we saw with other programs. So a lot is being done here, and I think a lot of accomplishment, but there are still some gaps in some of the countries, as you can see from this my slide. Based on our PEPFAR, our indicator now, or the target for EID 2 months coverage is actually 95%, but this is down to 90, and just over 5 hours, our PEPFAR supported countries have hit that 90% target of coverage for infants in 2 months, which means we still have significant gaps to cover. So need for us to improve, need for us to think about innovations and best practices. Then just thinking about what is the way forward. I'm always very, very excited when I find myself in a meeting with Solange Baptiste, because I think she is one person that I've seen a very strong advocate with lots of innovations on community engagement. So Solange, thank you so much. I know in your last slide, you actually reminded both PEPFAR and Global Fund to do more in terms of community engagement. So in terms of what we see as the way forward is community engagement to increase demand for viral load testing and EID, just as you said, Solange. And of course, there's a need for us to move down to that community engagement, think about what are the tools. Household sample collection is a good approach. We've seen that, and I'm going to explain more in terms of moving to the 6-month MND and the need for also to catch up with the viral load sample collection and testing. There's also the need to improve turnaround time, and that can't happen until we get closer to the patients and improve on our data systems. The use of point of care is the way to go, and I don't want to belabor the point because we said so much about this. gave the final approval, and we are just on target with that one. And also quick action on viral load results. And the last mile delivery is actually the new approach to supply chain management, which PEPFAR is rolling out. And that has helped a lot in addressing some of the challenges we saw, particularly with the impact of COVID-19 on supply chain. So moving forward again, TB is something that I don't want to belabor the point because it's been challenging over the years, but we've seen more recently that some countries have just developed more innovative approaches like South Africa, Uganda, Kenya, Nigeria, really addressing both HIV and COVID and TB at the same time. But one thing that I want to really remind everyone is the TB LAM, which is actually the point of care test, is not competing with these instruments for viral load or COVID. So there's just no excuse why countries are not doing so well with the TB LAM. So there's a lot of emphasis in the PEPFAR guidelines on how to improve on this basic TB LAM testing, and also special focus on children because of challenges with sample type. That is all something we mentioned last time, but again, pay a lot of attention on this. And of course, we're talking about what are the different options out there. We're talking about CD4 is something that has been seen through a different lens within the PEPFAR program. But the good news is that this time things are different. PEPFAR is opening up to the CD4 initiation. Is going to be now like baseline CD4 for everyone over 5, really trying to address issues around advanced diseases. And people also reinitiating care after a while. And we've seen this also in some of our programs that people with biologic failure needs who are returning to care, there's a need for us again to make sure that we look at the CD4 and see where they are. Most importantly, PEPFAR is moving in this direction because now we have this point of care cassette called a VC tech. That is what has delayed progress in the past. We feel that minimal funding from PEPFAR could be used more in supporting viral load. That has been the conversation. But now that we have this point of care test, we are really encouraging our country programs to use this. We're not going to support the procurement of any CD4 machines for this purpose. If the machines are there and already being used, very good, support those machines in terms of reagents procurement and then maybe service maintenance, but no additional instruments for this. If you don't have those instruments, you can use the VCDEC point of care test to support your programs. Of course, the diagnostic and network optimization is something that we've talked about all the time. We've seen benefits of this strategy, and of course, wherever you're sampling, we see improvement. It's going to help us tell us where the machines are. You want to talk about your sample transport system. That cannot happen until you have a full optimization of your country systems, your data systems, supply chain, and the waste management. So that is a key activity that PEPFAR is supporting moving forward, and we want to see it happen all the time. I would not stop talking about these integrated diagnostics. I know Anafi talk about it, and I see it all the time. WHO did a great job by sitting in Geneva with us in July and saying this is the way to go. So PEPFAR is laying a lot of emphasis on diagnostic integration and multiplexing. These slides, again, I'll continue to talk about them. We saw the benefits of multiplexing in terms of integrating COVID-19 and all the other diagnostics. We also were so excited on the left of my screen that a lot of our diagnostic manufacturers have actually upgraded their platforms, either in terms of software or replacing, and they can multiplex. So there's just no excuse why we should not do this. I'm using this slide just again to decipher this notion that when you go through the multiplexing, is going to impact TB or other testing. We see data. This is excellent data coming from Malawi, Zimbabwe, really showing the impact of diagnostic integration. And in all this really well conducted and published data, we've not seen anywhere where it is impacting other TB or other program. Instead, it is very, very positively impacting improvement in overall testing coverage and also accelerated enrollment into treatment program and retention in care. So we have to think about moving this way. Good examples from Nigeria and Uganda, as I mentioned, countries that have done so well. On the left, Nigeria really showed how they were able to integrate both COVID and TB and showing tremendous improvement in both COVID and TB testing. Same thing with Uganda. They went through really having this MOU with the ministry signing an MOU with Cepheid. That also incorporated a demand creation. Demand creation, I'm again so excited the way Solange put it, is a key for us to move forward. create demand and also think about your diagnostic integration and multiplexing. For the case of Uganda, it did not just lead to improvement in TB testing, but tremendous reduction in turnaround time. Nigeria, again, put in this data, we talk about the impact of TB testing together with COVID. This is really showing how Nigeria was able to integrate COVID together with viral load testing. Tremendous improvement. Look at it from QY, Cure 2 of 2020, right up to the Cure 3 of 2021. Tremendous improvement in viral load testing in the midst of COVID. Good news. And this is an example of a program that have worked so well. I really want to use this slide. I think I presented this during the LSM to make a point here that what we are saying is not just to sit and say, I have all the sophisticated laboratories, I have all the instruments, but it's for countries' program to really develop their pandemic preparedness plan. And once that happens, you really have to just to activate this plan. This is an example of Uganda, and I think many other countries that were ready for COVID just had this sort of plan where you start from the beginning, be holistic, bring in all stakeholders. You start by developing your COVID response plan. I'm sure it's not being developed, but the country has something in place that is simply activated. And you see, this country went from February 2020 right up to May, June, they were ready to go. So this is really what we expect to see all the countries. And if we do this, there will be no impact of COVID testing or other pandemic testing in other diseases. It happens in some cases because countries themselves are not prepared for it. There's just sort of no coordinated interventions. Now we have talked about challenges with supply chain that we saw all through COVID period, but there's a need for us to get ready all the time. And PEPFAR is strongly advocating for the all-inclusive pricing. We've seen that in our PEPFAR guidelines, past and present, that this helps us really move some of the responsibility to that of the manufacturer. And we're seeing the impact in terms of service and maintenance, instrument installation, and also addressing issues around sample backlog and also stock out. So more emphasis should be on walking away from instrument procurement and also incorporating aspects of diagnostic integration. We have what we call the global RFP that was launched, and I'm so excited that I'm sure some of my PEPFAR colleagues, particularly the USA and other colleagues from CDC involved in this initiative, that we've seen tremendous improvement in terms of moving away from that outright instrument procurement and going through the global RFP. Anticipated almost 20 million gains, just imagine with this period. I think it's maybe more than what I'm talking about. And also the fact that this is fully being supported by a lot of our PEPFAR countries. So when we look at our program, what we call minimum program requirement, we are expecting all the PEPFAR supported countries to move into this RFP and walk away from that sort of outright instrument procurement to a diagnostic integration and also involving all-inclusive pricing. Then of course, how have we felt to address all these challenges in the midst of COVID? I really don't want to repeat what has been said all over the place, but just to call our attention to the fact that it's been different. And I'm glad Solange brought up that community engagement, that as we move out into the communities, there's a need to think about the new strategies. Most of the PEPFAR programs have moved into what we call the 6 months MMD, that is medication and dispense at the 6 months, and no more people coming to the facilities. And we saw that this impacted viral load because it did not provide room for sample collection. So we tried to really harmonize the delivery of the medication or dispensing medication to coincide with when the viral load sample will be collected. If not, of course, we'll move to the community and make use of more of the GBS or the plasma separation card to support viral load sample collection and testing. In that case, you have to address your data system and also your sample transport systems. We've involved all the other options, including what I mentioned earlier about the APA funds and working closely with our Global Fund colleagues with the C19 and prioritize EID and viral load for special populations as a need may be. And of course, waste management, I really I don't want to belabor the point. My colleagues from CDC and also as I've talked a lot about this. So that is the way to go as we talk about all this instrument utilization and reagent that we procure, make sure systems are in place to address waste. I did mention what we call the minimum program requirement, that we are saying if you can't do all, do at least this. Of course, implementation and the use of point of care and instrumentation is what we've said all over. TB, HIV diagnosis, integration, and multiplexing, and the using of your data system are the basic thing that we want to see all our program implement. And of course, Again, we pay a lot of attention to collaboration. Again, the IDC that we all work together. I think everyone in this forum is part of the IDC, is the way to go. Work as a team, coordinate, vertical initiative. And most importantly, I think we've seen what African CDC has done for us, coming in just 5 years and really taking it and running away and leading all of us in Africa to implement activities, and need for us to work closely with African CDC. Just see what the ASLM is doing today. That is the way to go. So PEPFAR strongly encourage our country teams not to work silo, but to work together with all the stakeholders. We have key policies there that really focus on the lab, really addressing what we talk about, the need for policy change for multiplexing that we talk about to address COVID-19, and I would say pandemics and include TB, HIV, and other diseases. And a policy change for all-inclusive pricing is all in the COP guidelines. So we want to see that move forward. Country teams take this seriously. The policy change for POC, and of course, the network optimization that I mentioned earlier. So just before I wrap up, I have a question here for all of us. Are we really, are the laboratories within the African continent ready for the next pandemic? That question is up for all of us to respond to. And I think I really want to put that on the table of the ASLM. Let's really look at what happened in 2013, 2014, when we had the Ebola outbreak. Some of us were there. In fact, I was in Guinea leading the CDC Ebola response, the lab team. And we thought we were ready with all the sophisticated instruments that came in, the P4 laboratories, all the machines. And when we walked out of the 2013, 2014 Ebola outbreak, were we ready for the next pandemic? I don't think so. We were just last week or so, 2 weeks ago, attending the ASLM conference where we had two keynote speakers. I think we heard first from Dr. John Kengasong, really telling us how he had to really rally the African CDC and all the partners in Africa to get Africa to ready to start testing for COVID-19. I think he said just about 2 or 3 countries were ready, but just the presence of African CDC and support with WHO and other stakeholders, teams were able to move forward. We also heard from Dr. Tom Frieden, who actually put us on the spot. He reminded and told all of us that we all failed the COVID-19 test. He was right. Just in line with what Dr. Kengasong said, we're not ready. So are we ready for the next pandemic? So I think for the African Society for Laboratory Medicine, I think why not really refocus? I mean, we are doing a lot in terms of really getting all these pieces together, but let's think about strengthening laboratory systems in Africa with having the next preparedness for next pandemic in focus. If you can really think about what of your next activities or refocus one of your activities, and then I think the stakeholders are here. I think I saw Tadi and Peter from Gates Foundation, CDC, Global Fund, all the people supporting African CDC, and African Society of Laboratory Medicine. They're all here. So really repackage your initiative, really think about that big picture, perhaps put it in the context of preparing laboratories in Africa for the next pandemic. Could be a big picture that embodies everything that we've been talking about. So with that, I really want to thank all of you, thank African Society for Laboratory Medicine and all the stakeholders for really putting this together. And we look forward on how you can work together with PEPFAR and our implementing partners and our country staff in really moving activities forward. Thank you so much. Over.
Thank you very much, Dr. Alemji. So that's a lot of support from PEPFAR. He's just taken us through the different activities that PEPFAR is supporting, from viral load testing, EID, HIV rapid testing, including self-test and recent tests, diagnostic network optimization, waste management, supporting multiplexing, supply chain management, looking also at policy issues to improve the overall landscape of lab systems, and looking at our lab system strengthening as a whole. And it's not just improving systems for management of HIV, but also for the other lab tests that we need to do, and most importantly, preparing us for the next pandemic. The labs are ready for the next pandemic, and this is done through lab systems strengthening. Thank you very much, Dr. George Alemji. May I remind all of us to put down our questions in the chat box. We will have a question and answer segment after the second speaker has gone through their presentation. Juliet Bryant, welcome, and over to you. You can take us through a presentation from Global Fund.
Thank you, Nora, very much. I have a much shorter presentation than George's excellent one that he's just given, and hopefully we can catch up on some time. So this slide here, the first one is maybe the most important because I have written on it the group email for the RSSH Labs team at the Global Fund. At the Global Fund, I think we realize that labs are becoming increasingly important, and that some of the ways in which we structure our processes has not always enabled labs to have a lot of visibility or to be very involved in the preparation of funding requests. So my most important message for my presentation today is to really encourage all the lab leaders out there to be very proactive in being involved in funding request preparation and to learn about how to do this through our other processes. So next slide. So this is now a really interesting time to be working at the Global Fund. I only joined last April, so I have a newcomer's perspective on a very complicated organization. But it's such an interesting time to be there because we have just published our new strategy and are really thinking broadly about how to embrace this new world we are in with the COVID pandemic and trying to prepare for future pandemic preparedness and think about how this will influence our operating model. So the new strategy really emphasizes a fundamental shift towards integrated, people-centered services, and really echoes a lot of the topics that Solange raised so articulately. The role of communities in responses. The thing I'd like to emphasize on this slide here is that among the different ways we're going to try to push for this agenda of integration is through really championing the role of national essential diagnostic lists in countries and encouraging them to adopt this framework and thinking about how defining these lists and tailoring them for their own countries and their own tiered laboratory networks can help improve access to diagnostics. Next slide. So the big question for us is how to most effectively push this agenda of integration, which everyone has been talking about. It's so important on the level of patients and how they interact with clinicians. It's terribly important for all the technology, and it's important for the ways that disease programs coordinate amongst themselves in the governance structures of ministries of health. What I want to recognize here is that we're all saying we want to have integrated diagnostic networks, but it's not always progressing easily in different countries to move in that direction. So I think we also need to try to reflect and understand what are the barriers and obstacles for why it's not moving more quickly in that direction. Next slide. So the Global Fund really invests significantly in labs. This slide shows over the last 3 funding cycles, since 2014, approximately 12 to 15% of our total budgets have been allocated towards laboratories and diagnostics. Next slide. And these investments are, in general, really heavily commoditized. And that means that the majority of our expenditures are on equipment, reagents, consumables. And this slide here shows the fraction that is the commodities versus lab systems investments and supply chain costs. So the small group of us, laboratory advisors within the Global Fund, are really trying to push for a shift in this ratio. We would prefer that funding requests really capitalize on investing in laboratory systems, because that would enable the Global Fund investments to be more catalytic and invest in sustainable changes. I think we all realize that purchasing equipment and commodities, although it's of course essential and necessary, that's a gap-filling measure, and in and of itself doesn't constitute capacity building. Next slide. So in addition, of course, to our core funding country grants for HIV, TB, and malaria, we have now gotten very involved in COVID response. So the C19RM, or COVID-19 response mechanism, has now dispersed more than $3.5 billion to the eligible countries. And as the key message on this slide is that that diagnostics and laboratory support within the C19RM is now 27% of the total budget. So this is nearly doubling the fraction of total budgets that are addressing laboratory needs and diagnostics. The other really large components of the C19RM have been supplying medical oxygen and therapeutics and PPE. So of the 27%, which has been diagnostics and lab oriented, once again, it's been very heavily commoditized. Next slide. So, oh, and I believe if you could click through, because I've got some subheadings here. Yes. So what we are encouraging all countries to think about is to really focus more on these strategic lab systems strengthening components, which are the familiar sorts of things that the LabCoP talks about all the time. Governance and management structures, critically important. Investments in equipment management systems, in digitization, and laboratory information management systems, data management structures, specimen transport networks, the critical importance of quality management systems, and then, of course, waste management. So these are the different components that we refer to when we're talking about trying to encourage systems level investments. Next slide. I see it's fading in. So I've spoken about the fraction of our budgets that are from the core grants and from the C19RM, which are devoted to labs. We also have other mechanisms for trying to support countries, and we call these the strategic initiatives. And these are different. These are in the sense that they are centrally managed funds. So the disbursements do not go directly to governments or our principal recipients. Rather, these are much smaller envelopes of funding that we can use within in a targeted way in countries to address the needs for technical assistance, to try to encourage different kinds of innovations and pilot different kinds of interventions. And we have such limited time here, so I'm going to talk in the next few slides about just some examples of the kinds of work that we're funding through these strategic initiatives. Next slide. So one of the examples is the Global Laboratory Leadership Program, which is a collaborative effort involving 6 different organizations. So it's the WHO, OIE, FAO, the CDC, the ECDC, the European ECDC, and APHL, the Association of Public Health Laboratories, which in 2017, these a conceptual framework for harmonized curriculum relative to laboratory training. And the list of countries I'm showing here on this slide are the countries that have piloted and have and are ongoing efforts trying to implement the delivery of this in different countries. So APA deal original conception. It's a 2-year-long program which involves mentoring as well as a didactic component, and very importantly, project-based learning.
I can't hear Juliet. I think we lost her.
Yeah, so I'm sorry. Such bad luck. I normally have, so can you hear me now?
Yes, I can hear you now, Juliet.
Okay, okay. So so this slide is giving you a glimpse of some of the other kinds of activities that we are funding from under our strategic initiatives. What I had wanted to say on GLLP, just to wrap it up, was this emphasis on it's from the laboratory perspective, trying to drive change through a people-centered approach of senior level training. So here, just briefly, on the left-hand side, I have listed some different components of a very new initiative for centrally managed funds that's targeting C19 needs in different countries. So here we want to strategically try to assist different countries to rapidly increase their C19 testing and decentralize this testing to make the best use of their existing platforms, improve their data management systems, and the activities in this these new activities, which are just getting started, will be coordinated by the African Union CDC as a key partner in trying to roll out this support in a large number of different countries. Next slide. So I wanted to say a word about diagnostic network optimization. Almost every presentation so far, yesterday and this morning, has somehow mentioned DNO. This is something which we all think has huge promise to really improve all sorts of different aspects of lab systems. Of course, the starting point is to do geospatial mapping of testing sites. And we have here on the left a list of countries, a very long and growing list of countries that are engaging in these kinds of activities. The Global Fund is supporting some of them, but it's usually multiple different partners that are involved in these activities. What I want to highlight here is that in some countries, this is going forward and it's really remaining HIV centric and focused. And that, I'm afraid, is something that really doesn't buy into this whole spirit of integrated activities. To me, it just does not make sense to speak about optimization if we're talking about only optimizing a particular network for one particular disease. So I want to drive home here a message to all of the many of you who are involved in DNO exercises, the fact that they really must involve a broader perspective and start mapping testing sites where testing is going on for TB, for malaria, for other emerging pathogens, and look at it holistically on the whole. So next slide. So the dilemma of maintenance and servicing, we know, is something which is, it hugely undermines the functionality of our testing networks. And at root cause is the lack of a sufficient number of bioengineers, technicians who understand these sophisticated equipments and are able to rapidly get on site to repair and fix all sorts of different molecular diagnostic equipment. Next slide. In addition to the lack of engineers, we also need to think about the contracting modalities that we use to interact with the private sector that is providing these instruments. And this is something that George has mentioned and others in previous presentations this morning. And what I want to highlight here is that the Global Fund fully understands that we do need to move in the direction of more all-inclusive pricing, contractual relationships with the private sector, so that we don't have such huge pricing difference between countries. We can have more favorable contract terms, and most importantly, so that we can try to address this real dilemma of maintaining the investments that countries are making in all these different platforms. and just to acknowledge the fact that having this negotiating with the private sector, the Global Fund as one of the largest purchasers of this equipment has this power, but it will involve and needs to involve multiple different partners coming together and thinking about how we can move in this direction together. Next slide. So I've thrown in a slide here about wastewater-based surveillance because the Global Fund has decided to open the door and think about moving in the direction of supporting this sort of activity on a small scale with some of our strategic initiatives as part of COVID-19 response. And I'm thrilled that this is now becoming a possibility because I think it has such huge potential. One of the many things it has in its favor is that it really can be a flagship One Health kind of activity involving the environmental laboratory sector. And it can be, and we hope it will be, very complementary to case-based surveillance and as part of a tool for understanding how much testing is going on and how much testing needs to go on and transmission dynamics in different countries. Because by its own nature, looking into wastewater-based surveillance, the data generated is not going to be dependent upon variable health-seeking behavior in populations. So this is just a small plug to have you know that we are trying to move in this direction and to encourage countries to think about including these sorts of requests in future funding proposals. Next slide, and my last slide. So the thing about laboratory system strengthening is that by nature, it can be the main way that we try to break down some of the vertical silos of national programs that we have, and drive this agenda for working more holistically for strengthening health systems. Our work on governance critically important. I know that that collaborators here and the LabCoP recognizes this. The need to have laboratory technical working groups which bring together all of the key players, stakeholders, and powerful constituents into coordinating the investments that are being made at the country level. Just a word about quality management systems. This is particularly important now for C-19 responses when many countries have been setting up more temporary or transient testing sites. We know how important it is that countries need to have accredited national reference labs that are able to drive the QMS systems in their own national lab networks, particularly through producing the sorts of panels that are needed for proficiency testing and oversight of the whole system. So the data management priorities are really salient. All of these different mapping exercises that are going on that are related to better understanding where services are being delivered and what types of services, and ensuring that when we generate this data, we have interoperable systems that function with the DHIS2, and the data can be used in the sort of exciting eLabs applications that were talked about earlier this morning, and putting this all together. So I thank you all for your time and look forward to questions. And sorry about the connectivity issues.
Thank you very much, Juliet, for that very informative presentation. Lots of exciting things coming out from Global Fund as well, looking at lab system strengthening, strategic initiatives, where countries can pilot certain initiatives and apply for funding from the Global Fund. That's very exciting. The Global Leadership Program for labs and diagnostic network optimization. Thank you very much. We will open up for discussions and questions for both Juliet and Dr. Alemji. So from the chat box, we have a number of comments, and we seem to have a lot of interest in the Global Laboratory Leadership Program. Countries are asking how they can join the Global Leadership Program. I think there are two comments, Uganda and Nigeria. And then if Juliet, you can take that. Then there is also a question for Dr. Alemji, requesting a clarification on reagents. It says, thank you, George, for the response and clarifying this burning issue in our laboratories. I think this has already been responded to on stockouts of reagents. Maybe Juliet, if you can respond to how countries can join the Global Lab Leadership Program.
Certainly. So the GLLP is still what I would call in its pilot phase, and the Global Fund is funding its implementation in 6 countries. It's just getting started, and I think it's a very new sort of initiative for the Global Fund to support. So we wanted to start small and demonstrate proof of principle and see how things go. But I think the way forward would be for countries to request GLLP in their next funding cycle applications. And I think one other point to respond to what Pascal has written in the chat. I feel so sure that we have shared values and goals between all these different organizations, ASLM and AU-CDC, in trying to drive this agenda of integration. And I think I mentioned trying to reflect on the obstacles and barriers, because what's perplexing sometimes is that everyone is talking the same language and identifying and articulating similar strategies, and yet progress sometimes seems frustratingly slow. So I think that's something that we need to collectively think about. Over.
Thank you very much, Juliet.
Nora?
Sure, Dr. Alomji, you can go ahead.
Yeah, so thank you. Let me just give more clarity on this issue of chemistry and hematology tests, just to make sure that we are all on the same page. So what PEPFAR is saying is not that chemistry and hematology are not important for patient monitoring, but we are saying in the midst of maybe flat funding or minimal resources, what should you be prioritizing? We can now remind ourselves that in 2013, when WHO made a recommendation that we should be using viral load to monitor patients on treatment, there was a lot of funding that was diverted for CD4. But remember, PEPFAR said even though CD4 could be important, we should direct those funds to support viral load. And I think that is what has really supported this tremendous scale-up of viral load testing that we see today. So the same thing goes for chemistry and hematology. We are saying they're important, but in the midst of where we are, what is critical? And that is why more of the funding should be used to supporting like the viral load scale-up, also supporting early infant diagnosis. Remember, PEPFAR has now come back to the use of funding again to support CD4, particularly for advanced diseases, and also making sure that we go through the visit point of care that I mentioned. But that said, there's an exception. PEPFAR is still supporting creatinine, particularly for those on PrEP. So country programs are encouraged to look for funding, other fund from national program, or look for funding from other sources to support chemistry and hematology. That together would really provide us with a holistic picture, but PEPFAR is funding on really focusing on the essentials. Thank you.
Thank you very much, Dr. Alemji, for that clarification. Someone was asking for the slides from these presentations in the chat box, and Dr. Pascal has posted a link where you can go to download the presentation materials, and they've also indicated that they will be sent via email. Thank you very much, Dr. Alemji. Thank you very much, Juliet. I think I don't see any more questions from the chat box. So this brings us to the end of this session. I will hand over to Anafi to take us through the instructions for the group work. Over to you, Anafi.
Thank you, Nora, and thank you, Juliet, and thank you, George, for a wonderful session. Unfortunately, we are lagging behind, so we need to go into the breakout rooms. Again, those that haven't renamed themselves, I kindly ask you to do so, so that it is easier to put you into your groups. So just like yesterday, we go into our groups. You have the template that you already have for the country teams. But we are proposing that we make a slight sort of change to the approach so that we try and catch up on time. As you remember, yesterday we were sort of doing a post-mortem of the previous year. So the theme today is looking forward. So from your templates, I'm trying to share here, whether this makes sense. Yeah. So from the templates that you have, we had asked that you meet as groups. Again, you are meeting as groups. I think we're supposed to change here. All right. All right. So this is looking forward. So from each group, you have about 5 minutes per country. You present using the template provided. The only modification is is you may not need to go through all the slides, but there is a slide which summarizes it all, which is somewhere here where you talk about your 3 areas of weaknesses, how you have sort of contextualized them. And maybe you want to just give your priorities for 2022. We acknowledge these are not all of them, but we have said try to rank maybe your 3 most pressing ones. It may be difficult, but at least for the purpose of time, let's use those. So again, you may need to choose a rapporteur, but from our recommendation is the country that is involved in the agenda will be the one to present on the group. And in terms of giving feedback, also to gain time, kindly limit yourself to the common approaches that you have found within the group. And then you also list the unique ideas for the countries. Again, we have about 5 minutes for each country to present back. I realize this would mean we would have to go beyond time. So I kindly ask those that may be available to stay on a little bit, maybe for 15, 20 minutes max, so that we can then complete the program. So in the next few minutes, I'm going to ask my colleague to open the breakout rooms. You will find yourself automatically being shipped there. Those that will remain, I think we'll just try and assist you from there.
Hello. Hello.
Hi, we can get you loud and clear.
Diapo, s'il vous plaît. Concernant le deuxième aspect qui concernait le transport des échantillons, qui était notre deuxième faiblesse, les causes principales sont une absence d'une cartographie des ressources. Une absence de cartographie des ressources, donc on n'a pas suffisamment d'outils. Et sur le plan technique, chaque partenaire a mis en place des outils personnalisées qu'il faudrait que nous harmonisions pour être sûr que tout le monde fait la même chose. Et pour le faire, il faut mettre en place, élaborer une cartographie des ressources des pays, de tous les intervenants dans la chaîne des laboratoires et élaborer des projets de décision portant création d'un groupe technique de travail qui va permettre d'adresser toutes les difficultés que nous pourrons rencontrer. Il sera aussi question d'organiser des rencontres ou des réunions de coordination des activités de laboratoire au niveau régional et aussi avec les partenaires, parce que jusqu'ici, les interventions du laboratoire se font au niveau central. Il y a très peu d'actions au niveau régional, très peu d'actions au niveau district. Il faudrait qu'on harmonise ça et pour ça, il faut déjà créer un groupe technique de travail qui sera capable de travailler dessus et d'adresser ces problèmes-là. Allô? Est-ce que vous me suivez, s'il vous plaît?
Yes, we can hear you.
D'accord, ça me rassure. Le troisième écart identifié était l'écart sur le
Hello,
jet.
we're now in the general group, aren't we?
Ah, oh, désolé.
Okay. Feedback. Yes, so I think we are being shipped back to the main room in about 20 seconds. Looks like I think one or two of the co-hosts might have mistakenly closed the rooms. But anyway, we were left with only a few minutes. So I suggest we just go ahead with the Q&A and the discussion. Hello and welcome back. Let's just give a few more minutes for the colleagues that are in the breakout rooms to come back. I think they will automatically then close on their own in about 2 minutes. Let me start by apologizing for, I think, the abrupt shipping back into the main room. I think as we are trying to balance the need to have a few people being able to share slides there and making them co-hosts, one or two might have mistakenly closed the breakout rooms, maybe without intending to do so. So perhaps I think we need to move on and go into the discussion. I would like to call upon, Levi, are you ready? Yes, so maybe I could call upon the Zimbabwe group to perhaps present on the feedback from group 2. You would need the speaker. Yeah. I'll mute mine.
Thank you very much. Thank you very much. On behalf of Group 2, which had Zimbabwe, Zambia, Malawi, I will present some of the key priorities. 2022, focusing on the main domain where countries were identifying challenges and the goals, and as well as the targets as per the template. So for Zimbabwe, the key main domain that the country identified as challenging is reagent outages, issues around reagents, and the goal for COP 2022 is to have no reagent outages in the year with over 90% reagent availability. One other challenge that Zimbabwe team identified in our group was a challenge around human resources, particularly staff retention and staff turnover. And so the need for ensuring that the available staff is well trained in the guidelines, HIV guidelines. And so the focus here being to ensure that we reach a target of over 80% of the staff at the healthcare facilities trained. And then I think lastly from the Zimbabwe team is the issue around poor result utilization and management of high viral load results. And so the goal here being improved result utilization, as evidenced by results documentation in the patient cards, and the target here being 100% of the results being documented. And the next country there in the group, Zambia. Zambia identified that waste management and biosafety was a key domain of where there were some challenges, and the goal here being to develop in 2022 liquid waste management policy, and the target being that by the end of the year, this policy will be implemented in all the 10. And in terms of another domain as well, equipment harmonization, really in line with the diagnostic network optimization. And the goal here is to develop a standardized equipment placement and management policy with a target of effective equipment management and system being in place by the end of the year. Enhanced adherence counseling was the other domain identified, and the goal here being to include EAC accessioning in the electronic health records, so EHR system, and the target being that EAC information will be readily available at national level, being accessible through this EHR. The next country, Malawi, they identified again, like Zambia, that waste management was an issue, and that the goal was to finalize and disseminate and implement waste management guidelines, and with a target to have this implemented countrywide at the end of 2022. Supply chain management also identified as one of the issues, just like Zimbabwe. And the goal here being to finalize supply chain guidelines and develop supply chain monitoring tools. And these guidelines and tools by the end of 2022 are expected to be in place. Lastly, just like I think both Zimbabwe and Zambia, results utilization. So Malawi plans to implement an electronic results transmission system using SMS and USSD, and this is expected to be done during the year 2022. Lastly, Uganda, data management again, to standardize current patient identifiers and ensure that management of data around viral load is streamlined. So the target here being that 100% of healthcare facilities we will have the electronic medical records on site using this standardized patient identifiers. And I think the next one was really tracking of viral load samples, and the goal being by the end of the year to have systems for accurately tracking all samples, and the target being that all samples will be tracked, 100% of all samples will be tracked through that system. Lastly, just like Zambia also mentioned, I think the issue of waste management and biosafety, goal being to develop the policy and train all facility staff and ensure that by 2022, this is disseminated to all facilities. I think that would be our last slide. Thank you very much.
Thank you, Team Zimbabwe, for sharing. I'd like to call upon another group and also just remind, as to at least share maybe those that are common. For example, with the Zimbabwe, the group 2, I think you could see that waste management and the issue of result utilization was common throughout all the countries. So I think if we can share those, then we can then share the ones that are separate. Otherwise, great work from team group 2. Let's have another group that is ready to present. All right.
Hi, Anafi. I can present on behalf of the Francophone. Just I don't have a slide because we didn't have enough time. There were too many technical issues, and I hope that it will be fine.
Okay, thank you. Again, I'll ask
il paraît qu'une femme ne prend pas rien.
Okay, I'll ask those that are not speaking now to, so I'm going to mute all and then ask Pascal to unmute. I think you.
Yes, thank
Yeah,
you.
I'll ask also one of the rapporteurs there to take the brief notes as you go through the feedback.
Okay, thank you. So I was in the group with Burundi, Burkina Faso, Cameroon, and DRC, and I have to apologize for Cameroon because they started and they were interrupted, and Burkina Faso didn't have the time to contribute. But I went back to the presentation to have a look at what was proposed. So among all the common areas of weaknesses, I think that the supply chain really came very strongly from DRC, from Burundi, from Burkina Faso, and I don't think it was there from Cameroon. So that came very, very strongly. Also, I think that all the countries wanted to have a finalization of the laboratory mapping data so that there is a system where the data are available and then the data can be used to do diagnostic network optimization exercise. So, and whether or not that is supported by PEPFAR is not very clear. It might be that it's supported by the Global Fund. There was also 2 countries, I think there was Burundi, and that wanted to have QMS, quality management system, that is more intensified in the country. So they had previously some funding from the World Bank, etc. But they were worried that this is not addressed as a national program, and there was some comment from Dr. Samba that actually now there are some strategy to make this as a national program. It is, I think it's related to the Global Fund priorities. I'm not sure it's related to the PEPFAR priorities. Cameroon came very strongly on how to manage specimen, and not only specimen for HIV, but specimen across different diseases. And they need to have manual for specimen collection. They need to review the rejection rate of their specimen. And I noticed myself that there's a lot of overlap with quality management system if they want to monitor their specimen rejection rate. And also together with the specimen, they would like to have better turnaround time and hence specimen transport system. I think that creating demand was one of the priority from Burundi and also for DRC. And Burundi highlighted the lack of finances as a root cause, and there was a discussion that the lack of finances might be related to larger problem of laboratory governance and structure. And I think that's where, and also they mentioned SLIPTA as a strategy, and Dr. Samba mentioned that there is more than the SLIPTA. There need to be a lot of training on basic and advanced QMS, and there need to be a reflection on how you implement QMS at national level. And I will stop there. Thank you.
Thank you very much. Apologies for the feedback. Thank you very much, Pascal, for the wrap up of Group 2. I see additional priority areas from group one. I think we group one with waste management, supply chain, result utilization, issues of enhanced adherence, but we are also finding group one coming also with additional ones such as lab mapping, QMS, and mentioning strategies such as SLIPTA. I think demand creation is also something that I also picked. Also common there, I know group two had mentioned the issue
someone hear me?
result tracking. Please, can you mute if you are not speaking? Viral load result sample tracking, which is also similar to what FASO is also intending to do, which is around specimen collection and tracking rejections as well. So thank you very much. Let's move on to group, either group 3 or group 4. Anyone who's ready. Ibrahim, can you stop sharing, please? You are sharing your video. All right. Francis, are you sharing on behalf of your group? Can anyone hear me? Just to make sure I'm audible.
Yes.
Okay, great. So either group 3 or group 4, who is ready to give their feedback? None.
Yeah, hi, Nafi.
Hi, Collins.
Yeah, Nigeria is supposed to give feedback for group 4.
Okay, let me see. Nigeria, their co-hosts, they should be able to unmute. Yes.
Hello.
Okay.
So
please go ahead.
It's Mrs. Echubi's laptop. So we need to move the presentation from the other laptop to this laptop with which we're presenting. Okay. So if group 3 can start, it will be fine. If not, give us a few minutes, would present.
All right, thank you. Group 3, are you ready? South Sudan, Sierra Leone, Eswatini, and Kenya. I think this is ideally Sierra Leone presenting.
And after this, Michael, yes, Francis should be ready now.
Okay.
All right.
Francis, I think you should be able to share. Please go ahead. Maybe whilst Francis is trying to share, I can just open this for any reflections from anyone else based on what we have heard on the priorities so far. And I'm glad that they are actually sort of in line with what George and Juliet also presented. So in the end, I think we need to be thinking as these processes are coming. I think George talked about the COP22 coming through. What is it that we can do as country teams to ensure that these priorities are actually sort of included in the plans now? Because within the LabCoP, we talk of actionable plans. Sometimes if those plans are not sort of accompanied with certain sort of funding, they may not see the light of day. So for me, this is a call to you to say, at least we are prioritizing this. We are all agreeing, and the fact that this is from a multidisciplinary team, it really represents what the country needs. And I hope we already have started that first step in trying to prioritize what we need to put in the plans that are upcoming for our domestic funding, for our PEPFAR, for even the Global Fund issues as well. I also had a lot of interest in the GLP, and thanks to Juliet, she mentioned that these are the things that we need to be thinking of. So this is a platform that we need to use and make sure that we are ready when the time comes. I'm hoping that any of the groups is ready. Francis?
Nafi, France is having challenges in interconnectivity. Can I project on his behalf? And go ahead.
Please go ahead.
All right. So I hope you can see my screen. I'll quickly run through the priorities that the countries identified. And this group 3.
Hello, can you hear me? Hello?
Yes, Francis, we can hear you. We can hear you, Francis.
Hello?
Yes, we can hear you, Francis. Looks like Francis is having challenges with the internet. So maybe Michael, you can go ahead.
All right, thank you. So I just quickly put this together on behalf of Francis, but in terms of South Sudan, the area that identified the priorities for 2022 touches on waste management, sample transportation, demand creation, and decentralization of viral load AID testing to gene expert sites. And in terms of the funding for the same, they identified where the source of the funding is as highlighted. I hope I'm not over summarizing. For Eswatini, and I must apologize to the Eswatini team, they got this, there were challenges when they were making the presentation. We had to learn it from our end. Apologies, Team Eswatini. But for them, the area that they had prioritized include viral testing coverage utilization, the issues with referral linkages, supply chain, and biosafety and security. And specifically, they highlighted that biosafety and security at TWG has been formed for the same, and the waste management guideline have been developed. And they are currently, for supply chain, they mentioned that the issues of quantification and mapping of the resources, and they are currently having regular meetings with vendors and suppliers. For Team Kenya, they highlighted the issues of sample transportation. Yesterday during their presentation, they had mentioned the issues with this management, that they had developed a guideline. They're currently in the process of developing a guideline for GTC waste management, issues of supply chain, so that to ensure that they are not stock out, and demand creation to increase demand for overall testing services for people living with HIV. And finally, for Team Sierra Leone, they identified 3 areas which touches on viral load testing, supply chain, and equipment maintenance, the issues of resource utilization. And for the resource utilization, they are basically targeting to have 100% viral load and TAT for those people who are initiated on ART. Thank you, and over. Anavi, can you hear me?
Yes, I can hear you. Yes, I can hear you. Thanks a lot, Group 3. Maybe let's move on to Group 4. I hope they are ready now.
Can you see our slides?
Please go ahead.
Hello. Hello.
Go ahead.
Okay. So for the group 4, we had Nigeria, South Africa, Ethiopia, and Tanzania in our group. And presentations were made by Nigeria, South Africa, and Ethiopia. The priorities identified, the commonalities in terms of priorities, we had sample transport and supply chain management as the common areas that all 3 countries that presented had interest in prioritizing. But furthermore, we had for South Africa.
Can't hear you. You are speaking.
Can you hear me clearly? Hello, can you hear me?
We can hear you, but your slides are not moving.
Okay, sorry. Can you, is it on the, are you seeing the slides now?
Yes.
Can you see our slides?
We see your slides, but they are not moving.
Is it moving?
Maybe for the interest of time.
Okay, I would reshare. Let me just stop sharing and reshare again.
Just continue presenting it there.
Are you still up? Yes, move. Now move it. Yes, move it. It's moving now.
Okay, so can you see our slides now?
Yes, go ahead.
Okay, so as I said earlier, Group 4 had Nigeria, South Africa, Ethiopia, and Tanzania. Presentations were made by Nigeria, South Africa, and Ethiopia. And in terms of priorities, the commonalities were in sample transportation and supply chain management issues. Other priority areas for South Africa specifically included VL coverage and result utilization, demand creation. So, sorry. So for Nigeria specifically, we also had waste management. And for the plans going forward for 2022, Nigeria specifically had a finalization of policy on biorisk management and the need to increase buffer stock in country and also to increase storage capacity within the country. South Africa had plans or have plans to improve their monitoring and evaluation and also improve their supply, their specimen referral or specimen transport. So in terms of specimen transport or referral, Nigeria is looking at working towards harmonizing our referral transport system. And we're also looking at mapping our laboratories to have a comprehensive lab network in the country. Ethiopia indicated that they share similar priorities as Nigeria and South Africa in terms of sample transport, supply chain management, and even waste management. So we just tried here to capture the priorities for the different countries and also the areas of growth or the areas of interest or areas the countries would wish to do things differently in 2022. So in summary, that's what we have from Group 4. Over. Hello.
Hello. Thank you very much for sharing this. We are about 13 minutes to time. I just want to use the next 3 minutes or so for any quick questions based on what has come so far. Anyone can show by way of raising your hand. Okay, thanks. David, I can see. I'm told I'm not. It's difficult to hear me. I don't know whether you can hear me clear.
We hear you now, Anafi.
I guess I have bad network. Maybe Collins, you can take over and then we can move to the next session.
Okay, thanks. So the next session will be recognition, and David will share a few slides. Over to you, David.
Thanks, Dr. Collins. Can you hear me?
Yes, I can hear you.
Great. Hi, everyone. Congratulations on a great meeting. The last 2 days have been very informative, and we just want to share some recognition of all the hard work that's been done. We have 16 country teams, lots of stakeholders, and everyone does a great job participating. So we hope not to overlook anyone here. We just want to highlight some of the outstanding participation and recognize some of the country teams that have just gone over and above. So thank you, everyone. But we are going to share some recognition now. I'm going to share my screen. Let me know. Can you see this first slide?
Yes, we can.
Yes.
Wonderful. So our first recognition award here is for the countries with the highest participation in eco sessions, and quite possibly maybe these country teams can unmute yourself for just a moment and acknowledge yourselves. Let everybody see you if possible. So nice job, Ethiopia, Kenya, Nigeria, South Africa, Uganda, on the incredible participation. This is based on connections that we receive during our eco sessions. So congratulations to everyone. These eco sessions are incredibly important. So eco sessions are very, very important. So we really encourage stakeholders and country teams to show up as much as possible to benefit from the best practices that are shared and the experiences from your colleagues across the continent. Moving on to the next recognition here. This is for countries that have presented or shared during eco sessions. So it's not just the connection, it's the actual participation during the session itself, whether it be presenting your country's best practices or some other valuable information to share with everyone who's connecting to these eco sessions, as well as satellite sessions and this 2021 annual meeting. So again, you're welcome to unmute yourself and show your presence here, and we would like to congratulate Burkina Faso, Eswatini, Kenya, Nigeria, South Africa, South Sudan, excuse me, Tanzania, and Uganda.
Presented or shared during eco session, satellite session, and other.
Congratulations, everyone. So we're going to move on to the last recognition that we have here. And that's for countries reporting that data is available at the national level for most indicators of the VL cascades. And so these are the 5 teams that we thought were exemplary. And we hope that more teams will be able to also provide report the data that is available on national level from most indicators of the VL cascades. And that's Ethiopia, Malawi, Tanzania, Zambia, and Zimbabwe. Congratulations to everyone. Nice job. With that, Dr. Collins or Anafi, I'll turn it back over to you.
Thank you, David, and congratulations to the country teams on recognition. We hope to do this next year. For those who are not here, we hope to see you in the next round. Okay, so the next session we want to close, and we'll have some few comments from our partners. So I'll start with George from August. George?
Yeah, thank you so much, Collins. And I think this has been a wonderful opportunity for you, ASLM, to bring together all the countries and the partners to review what has happened over the years. And we all agree that a lot has happened in the midst of COVID. So thank you so much. It's been a great meeting. As we said, the PEPFAR action plan or the PEPFAR guidelines is really aligning with all what we'll be discussing today. We urge our country teams and other stakeholders to work collaboratively as a team, both at country levels and at HQ, so that all resources are put into a common basket. And as I said earlier, I think the target moving forward should really be thinking about our readiness for the next pandemic. So putting all that together, I wish you all the best, and thank you so much. Over.
Yeah, thank you, George. We are grateful for the support that PEPFAR has given us. Okay, over now to Juliet from the Global Fund. Juliet?
I think Juliet is gone, but Eileen is here.
Eileen, you can say a few words?
Oh, Juliet.
Is Juliet back?
Is Juliet back?
She says she's blocked. So
she's trying to unmute.
Yeah.
Let me check.
Ah, there you go. Yes, I was blocked momentarily. I guess what I'd love to do is just say a thanks to everybody for participating and for bearing with everyone with various technical problems. I think that it's a real tribute to ASLM to carry on and hold these virtual sessions. And I must say, I think I'm infectious. I'm a little bit feverish. So there are some benefits for doing a virtual connection where we're not all potentially transmitting to one another. So as I said in my presentation, and I shared the group RSSH Labs team email, we're a small team at the Global Fund, but we're growing. And what we really love and want and are looking for is more forums to discuss country by country with you, your needs and your priorities. I think this forum here, LabCoP, is something that we all think is incredibly valuable and we want to continue. So I just want to say bravo for all of the organizers, and then let's continue. We can continue in other formats with maybe smaller groups where we can dig down more into the country context. But thank you all very much for this opportunity to share and to learn from one another.
Thank you, Juliet. Yeah, thank you, Juliet. And we are grateful to the Global Fund as well for sharing the opportunities that the countries can then apply for. Thank you so much. Next, I will call upon Gesh from ICAP to say a few words.
Can you hear me, Colin?
Yes, I can hear you.
Great. Thank you, everyone, for joining this meeting. Honestly, it was a very informative discussion, especially the group discussion. Hope everybody really learned from other countries. And as usual, this meeting is really, really important for sharing best practice and experiences. And I hope everybody benefited from that. I really appreciated LabCoP team for coordinating this one. And we know there are a lot of challenges, a lot of efforts from the background. And I also like to congratulate the countries for recognized today for their effort, for their participation and sharing their experiences. So thank you very much. And I really appreciated the LabCoP team.
Thanks, Gesh, and thanks for joining and to help as well. So lastly, I will hand over to Dr. Pascal to say a few words and invite Tandy, the funders, to say a few words, and then finally the CEO. Otherwise, thank you so much.
Thank you, Collins. And it's the end of those 2 days. And my feeling is that we didn't have enough time. I mean, we discussed a lot and we shared a lot, but I can see that it would have been, you know, there was a lot more to say, but I think that we made a lot of progress. I am very grateful for the time that the countries have put into this. I am very grateful for the stakeholders, PEPFAR, the Global Fund, and other partners that stayed all along. Without, you know, this collaboration, it wouldn't be possible. So please, for those countries that feel that there's not been enough time, I acknowledge that. And the LabCoP team is still available to help finalize and moving those plans forward and further with all the best practices. So we are there for you. So please don't hesitate to call upon us, and we'll check. There will be follow-up emails. So thank you all for being you know, good partners and good participants during those 2 days.
Thanks, Dr. Pascal. So over to you, Tandy.
Yes, I just wanted to again congratulate the team for putting together an excellent meeting. This is a heavy lift, so I specifically want to call out Collins and Anafi and all of the others who spent time in the background putting together the agenda, getting feedback from stakeholders and country teams. You know, the effort was obvious to those of us who participated in the meeting. So thank you for that. I also want to say that you know, this continues to be a growing and this partnership continues to grow, and we're really seeing the fruits of the labor that have been put in the early stages and really starting to pick up steam. And your contributions are making ASLM more visible, and the innovation that all of the country teams are bringing in terms of you know, how to do this type of, you know, health systems and lab system strengthening, you know, across, you know, very different environments that, you know, others can learn from this. It's not just the 16 country teams that are here, but you're really creating, you know, global leadership in this area. So thank you, and I continue to applaud your efforts. Over.
Thank you for the kind words and your continued support. We will endeavor to meet our goals. Otherwise, I'll hand it over to the CEO to say his final words and close the meeting. Thank you.
Thank you so much, Collins. Let me start by congratulating all of us for such a very successful meeting. It has been very nice, and it has been very refreshing to me, especially seeing familiar faces and also familiar names. But not only that, but just listening to the presentations, what has been working, and also some areas of improvement, and also the discussions on how I think together we can continue to create these solutions and address some of these current problems. So very exciting 2 days. I also want to thank the country teams. We are humbled by your continued participation and really bringing your success stories even to this platform, and trusting ASLM. Really, that's really humbling to us, and we value that kind of partnership. I also want to thank even the Global Fund and PEP for listening to your presentation. Really, it's helping us and also the country teams in terms of how some of these priorities can be aligned to some of these funding opportunities. Really, it's been really great to just bring those two together. So I think what remains for me to say right now is that for all of us now, we have our priorities, we have our work cut out for 2022, and I really look forward to another exciting year, 2022, where we are going to be doing what we know best as the LabCoP, really, which is to share some of these successes, what is working, and also improving the diagnostic services, and not only stopping at that, but really looking at the bigger picture of improving our patient outcomes. So thank you so much for being here for the last 2 days. I know it's intense, especially if it's virtual, but really we appreciate even you making that time. And I would like to bring this meeting to an end and just say enjoy your upcoming festive season, but please stay safe. We are still in a pandemic, especially with the new strain, the Omicron, and have a wonderful day. Thank you so much.
Yes, I'd sum up.